Good morning, everyone. Sabah al-khair. This morning, thank you very much for joining us this morning for the third roundtable. Today, we're going to be talking a little bit about the implementation of the international health regulations, and specifically looking at challenges and opportunities in the Eastern Mediterranean region, and also the role that field epidemiology and the FETP programs can play in meeting core capacity requirements. My name is Claire Stanley. I come from George Washington University, and it's really a pleasure to be here. I'll let my other panelists introduce themselves.
Thank you, Claire. My name is Pierre Nabet. I work for WHO headquarters.
Thank you. My name is Wael Hayajni. I'm a pediatric infectious diseases physician at Jordan University of Science and Technology.
Okay, so I'll start by giving a bit of a global overview of IHR and some of the ways in which we think about meeting the core capacity requirements. And then Dr. Nabet will move on to talk a little bit more about the EMRA region, followed by Dr. Wael, who will talk again about the region and also specifically a little bit about Jordan. Okay, so I think everyone in the room is probably quite familiar with the international health regulations, but just to give a little bit of background, the international health regulations were renegotiated in 2005 following the SARS outbreak of 2003 with a greater recognition that there was a need for countries to collaborate to build the capacities to detect, assess, report, and respond to public health emergencies, and particularly those that threatened cross borders. The agreement entered into force in 2007 with the first step for states to assess their own core capacities, to plan and implement their capacity building, and then the idea was that all states would meet compliance by 2012. Had they not reached compliance by 2012, there was a possibility to request a first two-year extension through 2014, and then again in 2014, a second and final two-year extension. At the first deadline in 2012, only 42 countries had reported full implementation of the IHR core capacities. And it's also important to note that this is based on self-assessment. One of the aspects of IHR is that there is no external assessment that's enforced. In 2014, only an additional 23 countries had reported full compliance. So as you can see, there's still a large number of countries that have either not reported or have not yet fully met their IHR requirements. And this is really why we're here to talk today, because as you can tell, as the timeline implies, 2016 is really the end of the current monitoring framework for IHR. And so the question remains, can we actually achieve core capacity compliance by 2016? And if not, what comes next? And what are the ways in which we can support countries in meeting these obligations in the current, quite restricted timeline that faces us? But really, what did states parties agree to do within the context of the international health regulations? I'd like to focus on this idea: to meet minimum requirements to detect, assess, report, and respond to public health events, which I mentioned before. And I think it's very obvious to everyone here how field epidemiology can play a really important role in all of those aspects. Field epidemiologists are on the ground detecting initial signs of disease. They are the ones who perform the field investigations to assess the extent and impact of an emerging disease threat. They're often the ones to report through their system as to their findings during the assessment, and then may even be part of those rapid response teams that go out into the field to control the outbreak at its origin. Annex 1 of the International Health Regulations goes into a bit more detail about what actually these requirements are at the national, intermediate, and also the local level. And again, I think there's a clear role for field epidemiology at these multiple tiers within a health system. We can see even at the national level, one of the requirements is to provide epidemiological and logistical support to the process of assessing, reporting, and responding to disease outbreaks. In order to support the implementation of the IHR, the World Health Organization developed a monitoring framework, which basically broke down the international health regulations and those capacities described under Annex 1 into a series of core capacities. So there's 8 core capacities: laboratories, human resources, risk communication, preparedness, response, surveillance, coordination, and national legislation. In addition, there were 4 specific hazards that were identified. We heard about zoonotic diseases, zoonotic events yesterday in the second roundtable, but there's also food safety, chemical events, and radiological and nuclear events. And finally, all of these core capacities and specific hazards must also be implemented at all points of entry. Now, just moving track a little bit, I think we've heard mention a few times about the Global Health Security Agenda. And just out of curiosity, how many people in this room had heard about the Global Health Security Agenda before this meeting? Who had come across it before? Okay, so some of you, but not all of you. And I think that that's where sometimes there's a bit of confusion as to how the Global Health Security Agenda relates to the international health regulations. And it can sometimes be seen to be maybe a conflicting set of mandated agreements that people need to fulfill. In fact, there's a lot of overlap between Global Health Security Agenda and IHR, and that was intentional. The idea of the Global Health Security Agenda was really to be aligned with IHR and to help accelerate and elevate progress towards implementation of those core capacities. And again, you can see that a lot of the core elements within IHR, surveillance, laboratory, preparedness, are ones that are also important within the Global Health Security Agenda framework. And again, these are also ones that are particularly important from a field epidemiology perspective. And finally, this is my last slide, just to note that it's not just the Global Health Security Agenda that provides a framework for helping to accelerate IHR. There's lots of health frameworks out there, lots of different agreements, lots of different initiatives, and they range from the national to the regional to the global, and they encompass both performance, so the actual implementation of activities, the process, the methodology by which those activities are implemented, and also the overarching policy behind some of those activities. And all of them can help in some way and contribute to the IHR capacities. So I think just the point to make is that it may seem like there's lots of conflicting things out there that need to be achieved, but in reality, if we think about how they can align with each other, we end up in a really strong position for actually showing how we can meet IHR competencies. And so there's a lot of support, perhaps sometimes from unexpected places. Thank you.
Okay, so I'm going to continue, in fact, what Claire presented to you. So, as you know, the IHR has been adopted in 2007. So it is a document that is, this is an agreement which is binding legally all the member states of WHO. It was adopted by the World Health Assembly in 2005. This is the result of direct instructions from states to WHO. And as Claire said, it does focus on national capacities. So this is also the agenda that was presented. So adopted in 2005, entered into force in 2007. There were a 2-year period to make the assessment for countries to make the assessment, mainly of core capacities on surveillance and response. Then in 2012, the core capacities were supposed to be implemented. But for a number of them, it was not the case, so they got a 2-year extension until 2014. And in 2014, there are a number of other countries that haven't acquired the capacities, and they have obtained a second extension of 2 years, which is supposed to end in May 2016. This is the status of acquisition of core capacities in the region in 2010 and in 2014. So you can see that roughly this is 75% of the capacities that have been acquired in the countries of the region. This is almost the same average as for the whole world. The capacities that have been the most acquired are response, surveillance, and those for which there is still a lot to do. This is mainly points of entry. This graph shows the level of acquisition of core capacities at global level and in the Eastern Mediterranean region. So in green, you have the countries that have declared to have acquired the capacities in June 2012. So you can see that at the global level there were 43, and in the region only one had acquired the capacities. In June 2014, so after the first extension, 22 at the global level, 22 additional countries had acquired the capacities. In the region, it was 7. And now, so in 2014, countries have requested a second extension. So at the global level, it was 84, and in the region, this is 13. So it's not N is not 11. It's out of the 21 countries in the region, 13 countries are still have requested a second extension and are supposed to have acquired the capacities by 2016. Recently, WHO EMRO has organized preparedness missions in the countries of the region. I just want to remind that the revised IHR was adopted because there was a need for adapted tools for fighting emerging and re-emerging diseases in a globalized world. But the Ebola outbreak has demonstrated that there was a weakness of nations, despite IHR that was adopted in 2005, there was still a weakness of national health systems in West Africa, and the capacities to detect, to prevent, and to respond to outbreaks were not in place. So in fact, EMRO, like other regional offices, have decided to conduct preparedness missions in the countries in order to see how the capacities for surveillance and response were in place. And this is the results. So the first one is that, in fact, there is a need for objective assessment of core capacities. The second one, this is that there is an over-reporting of level of IHR implementation. You have seen that globally 80% of countries consider that they have acquired 80% of capacities. It was the same in West Africa, but when the Ebola outbreak occurred, we finally understood that it was not so true, because in fact the countries didn't have the capacities to detect early and to respond adequately to the disease. In order to, when the countries ask for an extension, they have to propose an implementation plan. But in fact, it seems that, and this is what we have seen, the plans that have been proposed for the second extension don't identify clearly the priorities, and it has to be modified. The weakest, through the missions, the weakest capacities that have been identified, this is the emergency coordination mechanisms, the emergency response, the disease surveillance, infection control, and risk communication. And those that have a very limited capacities, this is those which are related to food safety, chemical, and radionuclear. So WHO will provide the support to countries to strengthen these capacities. So first, plans are to help countries in develop a realistic IHR implementation plans, to revise the national plans and to make them more realistic. Of course, to provide technical support to countries to execute the plans. To promote multi-sectorality. There is, in fact, the good implementation of IHR, good surveillance, good response requires that all sectors work together. So it means health, agriculture, education, etc. But very often it doesn't work. And also, as I said, in fact, every year the countries have to report on the implementation status to the World Health Assembly. So this is the figures that I showed to you. But we cannot be confident in them. So there is also a process now at the global level to see how we can revise the monitoring tool that permits to know where the countries are. So the targets for 2016-17 that are proposed by WHO EMRO, this is to have all the countries having acquired the core capacities by 2016, to put in place a mechanism to ensure the functionality of IHR core capacities, to be sure that the legislation framework is in place, to strengthen event-based surveillance. So in fact, most of the surveillance systems rely on information that is provided by the health facilities. But there are a number of other sources of information through community, through media, etc. So this is what is called event-based surveillance, and it has to be reinforced. To be sure that the designating points of entry are strengthened, and that there are also plans for all hazards response. Thank you.
بسم الله الرحمن الرحيم. Good morning, ladies and gentlemen. واسمحوا لي أيضا أن أرحب بسعادة النائب فاطمة أبو عبطة التي أصرت على حضور هذه الفعالية الصباحية رغم انشغالها بأمور أخرى. أهلا وسهلا. And I'm going to talk about from a physician perspective point of view, which might conflict a little bit with the experts' points of view. Okay, let me just show you what is this. This is King Abdullah University Hospital, which is located in Arantha city, which is 2 minutes from a port of entry of Syria, where 2 million people influx into Jordan in the last several years. So I'll start with saying that IHR deals with outbreaks in an apparently regular situation. In Middle East, we are to deal with outbreaks in apparently non-regular settings. And this really means that we are in need for meaningful and operational IHR regulations, which I don't know how to do it. This is a question for the roundtable discussion. Okay, so the EMRO region has identified 6 visions to achieve in Middle East or East Mediterranean region. If you look at them, it's elimination of specific diseases, like extending and elimination of measles, which I'll show you some different data after that. Expanding disease-free areas. We are not polio-free anymore in the area. Okay. Providing safe vaccines. How can you give vaccines in a very shattered country like Syria or Iraq or Yemen or even Libya or other countries? Curbing the HIV/AIDS epidemic, halving the burden of tuberculosis, and containing new and re-emerging disease threats like MERS. And all of these are affected very much with implementation and compliance of IHRs, very much. And as you know, that 1/3 of all diseases in the area in Middle East are caused by infectious disease. and 1/3 of the deaths actually are caused by infectious disease. So it's a big challenge, especially for IMRO region. Let me show you some good things, white things. This is, we were toward eradication of measles in the area, and you could see this is the vaccines level, and this is the measles level in these countries. And if you look in this slide also, you see how measles eradication process is going in the area. Even some areas are reaching 0 level per 1 million, and that was in 2013. And if you look at Jordan here, we are at 19.5 cases per 1 million citizen, but the situation is being changed, as I'll show you in a few seconds. So in 2007, just going back quickly, the WHO identified 7 areas of work to guide the compliance and implementation of IHR, which my friends already went through in details, especially number 2, 3, 4, and 5. And all of them, they depend also on multidisciplinary intra-country and inter-country cooperation, which is really another challenge that we might have to deal with when we talk about IHR compliance. And as Pierre said, there was a medium-term strategy to implement between 2008 and 2013 with certain core capacity elements to be achieved in this area. And let me show you just a few seconds. By June 2009, all countries in the area were supposed to have been able to assess national capacities and resources for core capacities. And in 2012, all countries should have developed a national action plan for attaining core capacities. What happened with that? In 2009, all of the countries in the region provided this assessment except Somalia. And in 2012, all developed, none was able to develop a national plan except Iran, one country out of the areas, just the national plan. This is, you can see, from out of 21 or 22 or 23, however you calculate it, in the IMRO, this is only Iran. So, and if you look again in 2012 analysis for the IMRO region and the progress made by the countries in 2012, regional implementation level of capacity requirements was 66%. Identified designated points of entry, all did that except Somalia. In-depth assessment of designated points, 12 out of 21. Reporting ports with authorization to issue ship sanitation certificates, only 11 out of 21 did that. Designated national focal points, all except Somalia. And for nomination of experts to the IHR roster of experts, 11 out of 21 only did that. So, as Pierre alluded to, an extension was given till 2014, then another extension was given to the countries of the region till 2016, and he told you what is expected in that time. I'm sure they will ask you for more extensions to obtain these compliances. Okay, what is about Jordan? Pierre showed you a similar slide. He showed you the IMRO region, which is the yellow line. The global, I'm showing the global average, which is also the red line, and the green line, the green column is Jordan. It seems we are doing fine in Jordan when it comes to numbers. I mean, as per legislation, 100% compliance. Coordination, 100% compared to 83 and 79. Response, 94. We have a problem with the human resources, if you consider it a problem, which is about, I think, 80%. So I think Muhammad has a lot of work now to do, to work on human resources. And as a fact, in the last month, there was a workshop done by EMPHNET in Jordan here for epidemiologists to learn about international health regulation. Am I right, Muhammad? Yes, this was done in Jordan? Yeah. Okay, so going on, and this is the what about, okay, let's look back into the reality of life. What happened in IMRO area since 2013? We still have MERS. MERS, as of yesterday, 566 deaths and 1583 cases, and mostly in Saudi Arabia and many other countries now It is all worldwide. It crossed the borders, actually, this disease. Despite all the committees, all whatever we do, it crossed the border. And in Iraq, it's cholera again. 120 cases, confirmed cases. I'm sure there are other non-confirmed cases. Cholera in South Sudan. Again, poliomyelitis. Jordan is polio-free since 1992. Am I right, Dr. Adel? 1992. And 2 years ago or 3 years ago, there were 37 cases in Syria and 1 case in Iraq. And there was some environmental samples from occupied Palestine that was proven to be, I think, of Pakistani origin. And this brings the issue of mobile human resources, whatever human resources you're talking about, human people around the borders. And yellow fever in Sudan and poliovirus, as I told you. So there are outbreaks going on. And outbreaks in areas where at least there is social unrest, armed conflicts, borders that are open. These are a lot of things that IHR has to deal with. So let's go back. We were planning in Jordan to celebrate measles-free country. In 2013, there were 2009, 10 and 11, 0 cases of measles in Jordan. And all of a sudden, we had this outbreak in 2013, and it was, of course, because of influx of refugees from Syria, 123 cases. Of course, we can report that we have designated port of interest, but the whole Jordanian board is a port of entry now. How many kilos, Dr. Mahmoud? 300 kilometers? They move across. Any part can be a port of entry. So again, we are back to zero square. And we have to do supplementary immunization activities for polio, for MMR, for everything. Thanks God, we keep Jordan free of polio. Till today, as of today, we don't know what's going to happen tomorrow and the day after tomorrow. Hepatitis A. Hepatitis A also, there was an outbreak in 2013, and you could see around 1,100 cases reported in 2013 compared to few hundreds every year in Jordan. Of course, the numbers are much higher than that, but this is at least showing you the trend of hepatitis A. Okay, another issue that nobody talks about too much, antimicrobial resistance. Antimicrobial resistant cross borders with these people, okay? And I'm going to show you these numbers from King Abdullah University Hospital, which I think it represents the situation in Jordan. We talk about methicillin-resistant Staph aureus coming up to 60 and 70%. Multi-drug resistant ESPL, like extended spectrum ESPL, very highly resistant E. coli, up to 60%. The same for Klebsiella, and much, much worse for Acinetobacter, which is reaching almost 100% these days, or 90% multi-drug resistant. These also move with people across borders. And remember, Jordan is a place for health tourism coming from everywhere. Health tourism, okay? Not terrorism, health tourism, okay? So there are a lot of challenges that we have to deal with this. And this was published actually in the International Journal of Infectious Disease. So what are the challenges that we are dealing with in an area that is not in a regular situations? We have social unrest in all the countries around. We have local conflicts and armed conflicts. Arab Spring or autumn or fall, whatever you want to call it. Terrorism-related issues. These terrorists are moving from area to area without permissions, of course, and they bring everything with them, okay? And that's why maybe the polio virus strain number 1 has reached this area. Open borders, antimicrobial resistance, internally displaced person, and don't ever forget also the pilgrimage and Umrah seasons. So this is the question. Are we in need, when you talk about international health regulation, actually it shouldn't be it should be an intellectual talk. It should be an operational talk, meaningful talk, looking for solutions in unregular settings, especially in the Middle East. Thank you very much.
Thank you very much. So I think that's exactly the question that we would like to pose to all of you. What are your experiences in the challenges and some of the opportunities as well of implementing IHR, and perhaps thinking about some of the specific challenges to your country and the region as a whole. And also, I think the idea of inter-country collaboration is very important within this setting. We're lucky to have representation from a number of different countries, and so it would be interesting to hear some of your experiences in these issues. So open the floor to comment and questions as well to the panel. Perhaps one question then to start with is, were any of the people in the room involved in the EMRO Ebola virus preparedness missions? Did anyone participate in any of those visits or missions? Yeah. Okay. Because I think it's interesting that, you know, we have a very large group of highly trained field epidemiologists and medical practitioners. And it would seem to be a very useful resource to be part of those types of missions. But if no one was involved, then that's kind of an interesting observation in itself, potentially.
Yeah, clear, there was. I think just few. In the Ebola preparedness, there are a special situation for Jordan also. And Dr. Abdullah knows that from the army, because we have peacekeeping forces all around the world, especially those areas where Ebola has emerged. So actually, some of the physicians from Ministry of Health, they traveled to that area to make some preparation of how can we bring these corps back. You're going to talk about that, Dr. Abdullah? Because this is IHR.
Yes, fascinating.
Yeah. Okay, if you allow me, thank you very much for this opportunity, Dr. Weil. Since the talk of Ebola outbreak in Liberia and in surrounding countries, and back to the consolidated WHO book in October 2014, at that time we have formed a joint committee from the Ministry of Health and the Royal Medical Services in order to come up with a plan for combating and for preparing at the national level, and of course to take care about and to prepare ourselves for our troops who were deployed in that area. At that time, we have around 2,049 personnel deployed in Liberia. And the plan was as the following steps. We keep them there, isolated in certain areas to take care of themselves. We have provided them with the necessary PPEs and certain instructions, and we raised their awareness about the disease itself, how it could be transmitted from person to person, and we asked them to avoid the conflicted areas and not to be in touch with dead bodies or other animals that in the area. And our concern was about some troops that were guarded the national prison in Liberia, Monrovia, and we isolated them for a while in order to make sure that they have the clearance to come back to Jordan. We kept them for 21 days and another double incubation period, so we kept them for around 6 weeks there, and we give them the clearance to come back. At the national level, the committee was in a continuous building up capacity and looking for solutions. Minister of Health, they have paid a big effort and they have designated a hospital. I think it was Al-Bashir Hospital with 100 to 120 beds, I guess, yeah. 150? 50 beds, yeah. 50 beds in order to receive such potential cases from that area. At the military level, our plan was on the table. We have succeeded to make a tabletop exercise. We have tested that exercise twice in our military units. We have designated a mobile hospital in Zarqa, somewhere 35 kilometers of Amman to be as a cohort isolation or a designated special hospital to treat and to deal with such cases. Thank you very much.
Okay. Thank you for the discussion and for the local viewpoint about Jordan and our area. I agree that there are some bugs, some pathogens. If we want to design international regulations for cross-border or port of entry, we have to customize that to our area like other parts of the world doing. I'll give you an example. There is a European country that wouldn't give you a visa to get into the system unless you have a nasal smear and to exclude MRSA because you don't have MRSA. So this is one point of difference among countries. In Jordan, like Dr. Wael said, in the hospital over there, they have high rates of MRSA. In the private sector, I did a couple of studies in 2005, 2006, some of them published, some of them not published. And recently, I noticed MRSA in the private sector is about 40%, 45%, and ESPL in 30%. But just a point of warning, is we lumped 5 years together. Maybe if we look at the trends, they are escalating over the 5 years. Even now we have what's called KPC, CPE, CRE, KPC, and they spread worldwide. There's an article as well published, I think, in the Clinical Infectious Disease, even something you may not be able to control at all, even at the port of entry. Travelers who go from country to country may bring new strains in their bowel to their country without having symptoms, and after arrive, they move it like NDM, etc., etc. Okay?
Okay. In West Africa, I mean, if the Ebola outbreak spread through all the region, this is in fact because the capacities were not in place. They didn't have the capacity to detect early any event, and they didn't have the response capacities. However, according to the monitoring tools they were using to report to the WHO, the surveillance and response capacities, 80% of the capacities were acquired in these countries, which was wrong, in fact, because if 80% of the capacities were acquired, there would not have been this big outbreak. So in Jordan, you also have very high figures. You said that you have up to 100% of acquisition of core capacities. Do you think that it is reliable, or do you think there are some efforts to make to try maybe to be more to fine tune the evaluation of the capacities?
Well, if you're asking about what are we doing or what should we be doing, yes, we have up to 100% of some of the competencies or capacities. However, we are in control of ourselves. We are not in control of others. Take, for example, Syria. Syria, I mean, whom you have to build a partnership with. You just talk about a global partnership with the Syrian Republic government. With whom? With the 1 million facts that are controlling the border. So I think the most important is to foster our country capacities, okay, and to control our port of entries. And I'm sure, I think, let me talk a little bit. I know that there is a focal point in the Ministry of Health, Dr. Asad Rahal from the Ministry of Health. They are leading the team, which is also part of it is the civil defense, the airports, the Royal Medical Services, and other concerned services. That's what we can work in. Multidisciplinary, inter-country efforts, with some efforts by Royal Medical Services with their forces at the site of the service outside. Otherwise, and my question, which I think I'm not for this session, but maybe for thinking at WHO level, when you need when do you need the IHR? You need them mostly when there is shattered system. Like, when are you going to get the polio from where? From Cameroon, from Niger, from Afghanistan, from Pakistan. And how can you deal with these systems? I think we have to come up with more operational, meaningful way. Maybe somebody from outside should work with these systems. Bear, do you have any idea about this?
No, I mean, yes, I think that you have to reinforce a regional collaboration. For instance, in West Africa, after the outbreaks, now people work on the building of a regional network for all the West African countries in order to try to detect, to strengthen cross-border activities first, but also to try to have each country helping the others. I mean, because there are some resources in some countries, other resources in other countries, so they try to put together all these resources in order to have not only a national approach, but also a regional approach.
I think just to add to that, I think there's a very interesting possibility for thinking more about regional compliance with IHR. So rather than focusing on the individual country, is to say, okay, if we partner with our neighbors, can we then go through the monitoring framework and see how we as a region actually meet those core capacity requirements? Because it really isn't enough if one country is able to say they've ticked all the boxes, if their neighbors are not able to do that as well. So there may be some opportunities for thinking about how we can help and facilitate those conversations between neighboring countries as well. And I think West Africa is an excellent example of where such an approach 5 years ago might have been very protective, but unfortunately wasn't done in time.
One example here. When the poliomyelitis outbreak broke in Syria, the UNICEF and WHO, they made a very big and very important role in controlling the activities in the contested areas and the government areas. And I think there was acceptance about that in Syria. Am I right, Dr. Bassam? This is what happened. And nobody talks about these things politically, but it was there. I mean, the UNICEF and WHO, they did that. And as of today, there are no new cases of polio in Syria, and none again in Iraq. So it was working, helping them doing the job.
Thank you very much for clarification of IHR. But you know, Dr. Wael and the others, and that surveillance system is part of IHR. And you know, our surveillance system is at national level, and usually monitoring and evaluation and continuous surveillance for the diseases, especially new trends coming through borders to the country. And we are aware of the national population, and usually we work with refugees at the border. But you know, sometimes the crisis is coming suddenly, and we need a lot of efforts to follow the issues. Yeah. Thank you.
Thank you very much for tackling this important issue and for the expert presentations. I think Dr. Wael, as a clinician, put his fingers on the pain. I'm going to speak about Yemen situations. I think the IHR is still flying on the air. It's not coming to the practice at all. I'm not speaking about the war situations, but even before that, from 2007 until the war emerged in 2015, what's happening regarding IHR. Still, it is more theoretical things than the practical things. And we participated, the Yemen FTP graduates and residents participated in the Ebola preparedness plan and the mission, WHO mission. And we identified a lot of deficiencies, especially in infection prevention controls at hospital levels. And we have also some studies done by our residents about the antibiotic resistance, and we have similar figure to Jordan, even worse there. So still, I think, still we are far away. Far speaking about 2016 as the second extension deadlines, we still need more extensions. So we have to look to another way to tackle these things and involve those working on the field, those working in different parts, not getting to write something on papers and just at the ministerial levels without touching the grassroots problems at the practical sides. So this is an appeal. Thank you very much.
Thank you.
Yeah, at the back, please. Dr. Faris.
Okay, thank you so much. Really, in similar gatherings, I always raise the point of mass gathering in Iraq and the role of WHO and other people in supporting Iraq in responding to the influx of large number of people really coming to such a mass gathering. And the minimum estimates, there are more than 10 million people coming from the 5 continents and bringing all their background health situation, and really it is a wonderful vessel for all potential threats, diseases, bugs, etc., to operate there. But honestly, till now, very little had been noticed on the ground. So I would like to raise this point, and again, and would like to hear from WHO people what steps they can do in this area. Thank you.
Thank you very much, Dr. Faris. I think that's an excellent point, of course, for many of the countries in this room. And I think that, that's where we can maybe look at some of the similarities between mass gatherings and other events. For example, the refugee crisis that's occurring throughout the region, which is also about an influx of people from many different countries coming into one location. So I think, again, whereas we don't necessarily have all the answers, there's maybe opportunities there for countries to share their experiences with dealing with large groups of people coming from different places, the disease they bring, the types of event-based and other surveillance systems that are put in place to deal with those issues, and perhaps use that kind of experience to develop some systems to put in place. Just one idea. Perhaps others, I don't know if we have any representatives from the Kingdom of Saudi Arabia in the room, or others who have experience with mass gatherings and may want to comment on that point, but just one suggestion. Okay, well, are there any other comments or questions at this point? Yes, 2, so.
Thank you. I'm Kasha Fajaz, and I'm from CDC. I would be interested in some comments, I know, related to the interaction between global health security and international health regulation. Maybe Pierre, if you can actually comment on that. I know that there were some comments which you made there, but because I think what I'm actually hearing is that, yes, of course, international health regulations are really important, and their capacities, and I've been to meetings with EMRO before where there are countries which have actually said that, oh, they need actually help from other countries in certain areas. They talk about points of entry, they talk about, surveillance, disease surveillance, they also talk about like laboratory strengthening and so on and so forth. But what I'm actually hearing from Dr. Val, from you, is that, how do you operationalize international health regulations? And that's what I'm. But that is the crux of the main focus. So so I think the global health security agenda is supposed to sort of interact and support the international health regulations and countries to basically achieve their core capacities in a timely fashion. I think that the goal which was shown on one of the slides about getting all the countries to be compliant by June of 2016 still is is a huge task. So I think that I would be interested in the comments from all the panelists on that particular aspect. Thanks.
Okay, thank you. For myself, I don't see much difference between IHR and what is proposed by GHSA, because in fact, yes, GHSA focuses on the strengthening of capacities for response, for surveillance and response. And I was recently in West Africa, and in fact, there are a number of initiatives that are taken for reinforcing surveillance and response. So it is done through GHSA, but it is really very closely related to the plans that have been developed by the countries for strengthening IHR. So I mean, there are a number of missions also that were organized in countries by, before implementing GHSA, before in fact designing the projects for GHSA. And in fact, very often the tools that were used were the tools that were developed for IHR. So really, for me, this is really very closely related. And WHO is part of the initiative, in fact. And yes, I mean, GHSA is a good opportunity because there is a lot of funding, there is a lot of resources that are available for this, and this is an opportunity that should be and that is taken by countries for strengthening their IHR core capacities.
No, I of course completely agree with that comment, and I think I would just add that the element of GHSA, which I really liked seeing, is that there's an emphasis on prevention. And I think that's something that's slightly missing from the international health regulations, since they're really focused on early detection and then reporting and response, but there isn't that emphasis on stopping the emergence of disease in the first place. And I think that emphasis on immunization, on zoonotic diseases, on antimicrobial resistance, and on biosafety, biosecurity that's included within GHSA adds a really nice element to support what's really the essence of what IHR is all about. So I think exactly, they're complementary. It's great that there's funding associated with GHSA that's actually helping to operationalize some of these things, which, as we've seen, is very difficult sometimes to put into practice. It seems to be very theoretical unless you have the funding and the support and the technical support to actually implement it on the ground. And so hopefully we can sustain some of what's happened in the wake of the tragedy that has been the Ebola outbreak and use those lessons learned to actually do some good on the ground in other parts of the world as well.
One of the eight core capacities is about prevention, because it's preparedness.
Okay, yeah, but it's preparedness to response, not stopping disease emergence.
I think we have to move, yeah, Claire, because another session will be starting. Oh, already started. Thank you, everybody. Thank you for being here.